Welcome, and thanks for joining us. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to pass along our sincere appreciation for your interest in our educational webinar series. Our topic today, borderline personality disorder in adolescence. Recognizing BPD in kids and teens can be challenging, as adolescence is often marked by intense emotions, and it's not unusual for young people to experience mood swings or act impulsively. So, how do clinicians, parents, and educators spot emerging BPD in adolescence? And what does effective treatment look like? These are questions that we're going to explore in depth over the next hour as we chat with Dr. Wendy Bammatter, a licensed clinical psychologist specializing in dialectical behavior therapy for adolescents and young adults. She is a program leader within McLean's Child and Adolescent Division and an instructor in psychology in the Department of Psychiatry at Harvard Medical School. Wendy, thanks so much for your time today.
Thanks so much for having me.
Well, I want to start by asking you to help us understand just what borderline personality disorder is. How would you define BPD?
So there are many sort of different ways of thinking about BPD. Where I'll start is with the standard DSM diagnosis definition. The DSM is the Diagnostic and Statistical Manual of Mental Disorders that we use. That we, clinicians use to understand psychopathology and diagnose it. And then I'll talk a little bit more about how different people of different theoretical orientations might understand BPD. So just at its baseline, when you're thinking about BPD, it is really a disorder of pervasive instability. So I think that's the first thing to think about. A disorder of pervasive instability, especially in a number of domains, including pervasive instability in terms of our sense of self, in terms of our ability to manage emotions, and certainly people's ability to manage relationships. And then in addition to those domains that are affected, there is a real impairment in impulsivity, where folks with BPD are thought to have much higher levels of impulsivity. So that is, they engage in behaviors quite reactively without thinking, slowing down to think about the consequences. So when we've got BPD sort of outlined like this, the other things to think about in terms of the diagnosis, especially for adolescents, is that adolescents, in order to get the diagnosis as an adolescent, you have to have had these symptoms, met the criteria for at least 1 year. So that piece is important, whereas that's not the case for adults. But regardless, it is a pervasive pattern of instability. So that's that. Is that all right? I'll keep going.
Please. No, this is a great starting point. Let me interject one question just by way of perspective. How new is the diagnosis itself, historically speaking? Is this something that's been diagnosed for decades?
Mm-hmm. So a long time ago, in the 1930s, there's a psychoanalyst, Adolf Stern, who started talking about the concept of what it means to be borderline. And that, I want to highlight, is very different from our current conceptualization of borderline personality disorder. But in the 30s, the word borderline was around. People were talking about it. And Stern talked about it as a way to distinguish patients. Some of the patients that he was seeing were all the way on one end of a spectrum, where they seemed like actually psychotic. And then all the way on the other end of the spectrum, folks were more neurotic. So you're sort of more standard depression, anxiety. And he found that people in the middle sort of were on the borderline, essentially, between psychotic and neurotic. And then fast forward a number of decades, in the 1980s, the term borderline personality disorder came, and it was included in the DSM-3. So that's when our current understanding of borderline personality disorder really came about.
And let me ask you also about this term dysregulation. We sometimes hear about common dysregulations when it comes to BPD. What should we know about that term, and what would you like us to know about those dysregulations?
Yes, absolutely. I'm smiling because, as psychologists, we use that term all the time. And I think lay people are like, what is that word you keep using? So dysregulation has to do with really a profound difficulty managing whatever it is we're talking about in terms of dysregulation of the self, dysregulation of behaviors, of emotions. This is probably a good point for me to dive into talking about the 5 areas of dysregulation that we talk about specifically in dialectical behavior therapy. And these 5 areas of dysregulation map onto the DSM criteria. So in the DSM, in order to meet criteria for borderline personality disorder, you have to have 5 of 9 criteria present. And just to share sort of the math on that, if you do some fancy math that I don't know how to do, that's 256 permutations of borderline personality disorder. And I share that because BPD for one person can look vastly different for BPD for another person. And I think that's important to keep in mind as we discuss this. So dysregulation, we talk about 5 areas of dysregulation in BPD, and I'll start with emotion dysregulation. So when we're talking about emotion dysregulation, we're talking about somebody who struggles with emotion dysregulation. We're talking about somebody who has quite unstable emotions. The emotions are perhaps up and down. They're much more sensitive. They're more reactive. They take longer to go down the emotions, and the ability to manage them is very, very challenged. And so when we're thinking about, well, how does this show up in the DSM, this idea of emotion dysregulation, you see it with folks, for example, many folks with BPD really struggle with anger. We all get frustrated, we all feel angry, and that's a healthy emotion. It truly is. And in BPD, folks often get in trouble with their anger because it goes from frustration to rage very quickly. And oftentimes people feel out of control when they're feeling that level of rage. It's not a comfortable feeling. And so that's one of the examples of the ways that emotions can be dysregulated in BPD. Similarly, shame is an emotion that folks with BPD struggle a lot with, profound shame, feeling sort of toxic, bad at their core. And so really a hard time managing the emotions that are showing up. So that's the emotion dysregulation piece. And that really impacts all the other areas of dysregulation. And we think about it as sort of there's a bi-directional relationship between these different areas. So we've got emotion dysregulation. Then we've got dysregulation of interpersonal relationships. And just a side note, earlier I said, when you're thinking about BPD, people can think about it a little bit differently based on different theoretical orientations. Some people see BPD, for example, mostly as a disorder of emotion dysregulation, interpersonal dysregulation, disorder of like stormy relationships. And we absolutely in DBT see that as well. So the interpersonal dysregulation is really sort of, as it sounds, really having trouble with relationships. There's very little stability in relationships if you're somebody that struggles with interpersonal dysregulation. So this might look like, somebody, an adolescent, starts to date somebody and they're so excited, and this partner is like the best partner there ever was in the entire world. And so they're sort of idealizing the partner, not seeing any of the sort of negative flags or the red flags or what have you. And then all of a sudden it can switch very quickly to real sort of aversion to that person, to hatred, to anger. And so you're really flip-flopping in relationships. And you can imagine for the people that love those with borderline personality disorder, it can feel like you're on a roller coaster, right? You're not always sure what to expect. Is my daughter going to be really kind and loving to me today? Or is she going to tell me that I'm the worst mother that's ever existed, right? And so there's a lot of fluctuation. And this obviously can be really, really hard for everybody involved, especially the person with BPD.
Sure.
So we've got emotion regulation, interpersonal dysregulation. We've got behavioral dysregulation. And that looks like a bunch of different things, but essentially people with BPD often engage in really high risk behaviors. And often they're engaging in these high risk behaviors as a means of managing intense emotions and managing intense pain. And so those behaviors can look like risky sex, reckless driving, substance use, eating disorders, and certainly suicide ideation and behavior, suicide attempts, non-suicidal self-injury. And so, there's a spectrum in terms of the severity of these behaviors, but that's what the behavioral dysregulation looks like. Then we've got dysregulation of the self, which is really in BPD, we see folks struggle with an unstable sense of self. Like, who am I? What do I care about? What are my goals? Sometimes folks with BPD, you see this like switch a lot. Like one day I'm really into this, and the next day I'm really into this. And that can be tiresome to the people around them, but it can also be really confusing, leading you to feel like, I don't know who I am. And that's really painful. Sometimes, in this category, folks with BPD can have a sense of sort of emptiness, this sort of like flat emptiness, which is quite painful. So that's really the disorganized dysregulation of the self. And then finally, we've got, what have I not said? The cognitions, dysregulated cognitions. And so when you have BPD, and of course, all of us can have all or nothing thinking at times, but this is much more pronounced in BPD, where we have what we call non-dialectical thinking, which is this all or nothing, very extreme thinking. My mom hates me, or I will never be loved by anybody ever again after this breakup. That's sort of on the more benign end, and it can actually get much more serious to actually looking like a profound disconnection with reality. So when you're emotionally dysregulated, right, your brain is so flooded, and so our ability to think clearly sort of goes offline, and we then can get very cognitively dysregulated, and so that can look like paranoia. That can be actually a real sort of feeling of dissociation, like you're not here, you're not feeling like yourself. So it can be quite serious. So those are
So,
the 5 areas of dysregulation.
wow, great job walking through all 5 of those. You touched on this prior to breaking them down. What is the interplay between the 5? And again, remind us what needs to be there for a diagnosis of BPD.
So for the diagnosis of BPD, you have to have 5 of 9 criteria. And I would say, in terms of the 5 areas of dysregulation, you certainly do not have to have all 5 areas of dysregulation. One of the things as a clinician that I do when I'm meeting with folks who either have BPD or think they have BPD is we actually talk about the 5 areas of dysregulation, and we have them sort of talk it through with us, like what resonates with you? What do you find you're most struggling with? And then we ask parents the same thing. What do you see your kiddo struggling with in terms of these different areas of dysregulation? So you don't need to have all of them. And like I started to mention, there really often is quite a bidirectional relationship between them. So when you're emotionally dysregulated, you're more likely to be cognitively dysregulated. Your relationships are more likely to be stormy. You do engage in more dangerous, risky behaviors. And then, of course, if we're thinking about that bidirectional relationship, right? So I just explained emotion regulation, dysregulation, how it impacts the others. You can easily imagine how if you are cognitively dysregulated, you're thinking in all or nothing terms, that's going to then make your emotions even more powerfully painful, right? So if you're thinking no one's ever going to love me, your shame is going to go up, your hopelessness is going to go up. So there really is this intimate relationship between these different areas of dysregulation.
Okay, we're going to circle back to the areas of dysregulation because this is obviously very important. I do want to ask you, by way of perspective, what you can share with us in terms of prevalence. How common is BPD?
So BPD is much more common than people think. So there's, a statistic of 14 million Americans have BPD. So when you're talking about BPD in the general community, we see prevalence rates between 1.2% to up to 6%, which is quite high. And then I'll share with the adolescent BPD. For adolescents with BPD, we see prevalence rates in the general community of 0.9 to 3%. So again, quite significant. And then the percentages, of course, the prevalence increases when you're looking at folks in treatment. So when you're looking at people in outpatient treatment, for adults, you see about 10% of adults have BPD if they're in outpatient psychiatric treatment. And for adolescents, you see that it's the data show it's closer to 11 to 33 or 22%, excuse me, so higher. And then when we're thinking inpatient with adults, there's data that show up to 20% of adults in inpatient psychiatric settings have BPD. And for those with adolescents, there's some data that is up to 50%. So, 32, but up to 50%. So quite high.
So, Wendy, one of our goals with these webinars is to weave in some questions from the audience, and
Yes.
we're getting a lot of them already for you.
Good.
So let me ask you this because the timing is right. I was about to ask you about possible causes, and a viewer would like to know, is BPD hereditary? And if a parent has BPD, is it possible to prevent the disorder in kids if they learn skills early? So there's a lot to unpack there.
There
But
is.
let's start with the genetic portion. What do we know about the genetics of BPD?
I think we're learning more across time. So there's actually statistics in terms of heritability of BPD indicating that it is quite heritable. So there's studies showing between 40 to 69% heritability in BPD, so quite heritable. And then, earlier I mentioned impulsivity, which I'm sure we'll talk about more. Impulsivity is shown to be 80% heritable. So if a
Wow.
parent really struggles with impulsivity, we think of it as kind of like a trait. It is highly likely that the child will also have, more difficulty with that trait, impulsivity. To the
In ter-
question,
I'm
yeah.
sorry, go ahead. Let's address that question first.
Yeah.
Yes.
So first of all, very thoughtful of the parent who's asking. It's really nice to see parents really thinking about what are their own vulnerabilities and how can they support their kids. And I think being really proactive is important. I would say no, it's probably not. There's no guarantee that you're going to prevent your child from developing BPD. I wish we could say there was. And there is a ton that you can do. I think learning a ton about BPD, certainly I'll talk in a moment about how it manifests or how we think it manifests. And I think that can provide a lot of information around how to help either prevent it or intervene early.
One more related question before we move on from this. Is there a specific risk factor involved with BPD? Are there certain groups that are more at risk than others for developing the disorder?
Yes, certainly if you have impulsivity, that is one risk factor. Absolutely. When we're thinking about heritability, because BPD is heritable, that's another risk factor, right? The genetic loading is a risk factor. In terms of sort of what's going on in the brain, there's a lot of new research indicating that the serotonin system is really involved in BPD, so there's a risk factor. If the serotonin system, for example, is disrupted, there's a number of other neurotransmitter systems, but I won't get into all of that. And then in terms of like what are we seeing on the ground, what are some warning signs that this might be a kid that could ultimately develop BPD? Would you like me to address that now?
Sure.
Okay. So some of the sort of warning signs in children. When you are working with children, and of course, I just want to be really clear, any of the signs I'm talking about now, I don't want people to panic and think, oh, my child has this one symptom, they're doomed. So take this with a grain of salt. There's really a complex interaction of things that have to happen to move towards BPD. But we see that relational aggression in childhood is certainly one indicator of a higher likelihood of developing BPD later on. Um, Kids who are diagnosed with ODD, that's oppositional defiant disorder, ADHD, attention deficit hyperactivity disorder, they are shown to have a higher likelihood of developing BPD later on. And interestingly, if a child is smoking marijuana, I know it's kind of hard to think about that, but there are data that show children who experiment with marijuana are actually more likely to develop BPD later on. Certainly, you want to pay attention to traits like impulsivity, as I keep mentioning, and just really intense irritability. Intense irritability is that's one of the number one reasons parents bring their kids to treatment when they're younger, and that can be an indicator that BPD is en route, but certainly doesn't mean that it has to be.
Let's get into the tricky question here, and that's distinguishing between normal adolescent challenges and BPD challenges. And we have got the best viewers, and a viewer question just came in that phrases this better than I could. So let me just go ahead and
Oh,
read this. Please help distinguish between BPD in adolescence and quote unquote normal adolescence, which is also commonly characterized by emotional dysregulation, risk-taking behaviors, volatility in relationships, etc. That
was that
really
an
gets at
actual question? That's so
that was an
beautifully. That's
actual
like in a
question.
textbook.
Yeah, I'm telling you, we've got the best
Yeah.
viewers. So that really does sum up the $1 million question with this particular webinar topic
Yes.
today.
Yeah, that's a really, really important question. And we do want to be thoughtful of that. There are absolutely times when I think providers, parents, educators are at risk of what we call over pathologizing normative behaviors. So seeing, somebody is experimenting with drugs and we're like, oh no, this is awful. It's not good. And that may be really normal. So like this viewer stated, when you're thinking about adolescent development, it's normal to be exploring your identity, to have questions about who you are, what you care about. It's normal to experiment with different things. Doesn't mean it's always safe, but it is kind of normal to be curious about what's out there. And so that might look like, exploring your sexuality, taking some risks in terms of, sex and relationships with other people. It might look like experimenting with drugs. Certainly mood swings are incredibly normal due to changes in hormones. There's a lot that's really normal. And so the question is, when does it cross the line into abnormal, into clinical sort of areas of concern? So one thing that I think is helpful just to think about with this question is, no matter what you're seeing, we do want to keep in mind that these symptoms have to be present for a year, right? And so if you're seeing somebody, for example, we talked about some normative experimentation with substances, they drank one drink at a party, that's not as big of a deal as somebody who is using substances or drinking regularly across a year at a young age. That certainly is an area of concern. So there's that sort of 1 year piece that helps us to think about. And then the other piece that I think is helpful for parents, for clinicians, for educators to think about in distinguishing the difference here is there's really a number of things. One is the behaviors you're seeing that are clinically concerning are more extreme. So, your teenager might be moody. That's normal. That's so normal. If your teenager is frequently experiencing rage, such intense self-loathing that they start cutting, all of a sudden, that's not healthy. That's not normal anymore, right? And so, we can think about a spectrum, and when it gets more intense on that spectrum of severity, then that's a sign, this is no longer normal and safe. So there's the extreme piece, there's the frequency piece, which I mentioned. You see these behaviors more frequently in folks who have BPD or who could be developing BPD. So it's not one car accident, it's 5 car accidents, right? It's not going to the principal's office once, it's like every day. And so you see a repetition of the same behaviors. In some ways, somebody engages in a high-risk behavior, but isn't learning enough or doesn't have the skills enough to not do that behavior again, right? Then the other piece that I think is super important to think about is when you have BPD, a lot of the behaviors that you engage in that are really risky and dangerous, where parents are like, why on earth would you do this, right? They are often people engage in those behaviors as a means of regulating their emotions. And that's not as typical in normal adolescence. You don't, engage in really high risk behaviors to change your emotional state as often. It's more curiosity. It's more wanting to fit into a peer group. Whereas folks with BPD, there's such an intense level of emotional suffering that the decision to engage in a behavior is quite reactive and solves the problem in the moment of bringing their emotion down. Now, of course, we don't want them to be using those behaviors, but it does solve the problem in the moment.
Wendy, I've got a couple of questions for you about age of onset considerations. The first obvious one is, at what young age can BPD be diagnosed?
Yeah. So there's a lot less research, I will say, on BPD in children and adolescents. Certainly the field of research on adolescents is really growing in BPD, and even the field of research on BPD with children is starting to grow. Historically, people did not diagnose BPD for folks under 18. And the reason for that, it was really sort of a clinical error in some ways. One of the earlier DSMs provided sort of this very cautionary language about being, very cautious and very unusual to diagnose BPD under 18. And as a result, a lot of clinicians thought they couldn't. And so, the language has changed now to indicate you can diagnose BPD under 18. It just has to have these symptoms for a year. In terms of age of onset and what age you can diagnose, I'll start with the age of onset. There's not one particular age that I think everyone has agreed on, but generally we're seeing between early adolescence to early adulthood. That would be sort of the time frame that's most common to see BPD emerge. The DSM says, by early adulthood. And then what's the youngest age you can diagnose somebody? I don't think there's one answer to that. There is certainly research on folks who meet criteria, on children who meet criteria for BPD at 8 years old, at 9 years old, at 10 years old. I think what we traditionally try to do, and what's more important than at what age, is think about, okay, here's a kiddo in front of me. Here are the symptoms they're struggling with. How can I help them? Right? That's ultimately why it matters. A diagnosis, the utility of a diagnosis in my mind is to help us understand what's going on and to direct somebody to the appropriate treatment. And so, it's hard to say because there's not one age, but you certainly can diagnose it in younger folks.
Related question that came in from a parent. Do you have any recommendations for how a parent can proceed when so many practitioners believe that an adolescent cannot be diagnosed with BPD?
Yes. A couple things. If a clinician is really firm on that, I might say that's not your clinician, because it means that they haven't gotten the training that other experts have gotten on sort of the evolution of science in terms of how we understand. We know there's been studies that indicate we can reliably and validly diagnose BPD in adolescents, for example, that we still need more research. There are still flaws in the system, and the research indicates that we can do this to the best of our understanding. So that may not be your clinician. The other piece is, let's say you love the clinician and the clinician is really open, then turning them to reputable sources where they can learn more about BPD, I think is really, really important. And certainly we'll talk about resources across time. One I can mention is the National Education Alliance for BPD. That is just an absolutely incredible resource out there, NEA BPD in short. That's a really great resource for families, for people who love young people with BPD. And I'm sure they have a lot of resources there that the providers could learn about. But certainly providers doing workshops is really important to just continue to learn more about where the science is and how we treat these folks.
We're going to touch deeply, in fact, go more than just touch on. We're going to go deep into some treatment processes that are available for BPD. Before we get there, though, let's talk a little bit about diagnosis. And without getting us too far off into the weeds from a clinical perspective, what should we know about the diagnostic assessment tools, for example, that are used by professionals to officially diagnose BPD?
Yeah, I think, like all disorders, when you're thinking about diagnosing BPD, you want to do some kind of comprehensive assessment where you're taking into account family history, you're taking into account sort of what the symptoms have looked like across time. You want to do that kind of comprehensive assessment. And then there are specific measures that can be used. So for example, there's a couple for children. So the childhood interview for borderline personality disorder is one that folks can use. The borderline personality disorders features scale for children is another one that providers can use with younger folks. The Zanarini rating scale for BPD is one that I often use. And these are good metrics to help us understand what BPD symptoms are showing up and how do we help treat you. I will say one measure that I quite like that is not used to diagnose BPD, but instead helps us to understand as clinicians and researchers, what are the specific areas that you're really struggling with, and it helps us tailor treatment, honestly. And so that's the difficulties in emotion regulation scale, or the DIRS. And there have been a number of adaptations of the DIRS for folks who are younger.
I want to ask you specifically about misdiagnosis challenges. Are there particular disorders, bipolar disorder, complex PTSD, anything else that is misconstrued as BPD or vice versa?
Yes, absolutely. So I would say a lot of folks that that have BPD, or what we know from the data, is when people are seeking care, they're rarely seeking care, or not as often, thinking that they have BPD. They're often going for depression or anxiety. And then it comes to light that, oh, I think BPD might be a problem here. And so that issue is not necessarily, I want to be really clear, an issue of misdiagnosis. That's more an issue of probably comorbidity, where you have depression and you have BPD, or you have an intense anxiety disorder and you have BPD. Where we see more often the misdiagnosis is with bipolar disorder. And so with bipolar disorder, it's very understandable at face value how that can be, how someone could misdiagnose bipolar disorder, because you're seeing their affect lability. You're seeing emotions go up and down in a really intense way. You're seeing at times out of control behaviors. And so at face value, that looks a lot like BPD. And so it's helpful to slow down and think about, well, what are the different characteristics here? Of course, bipolar is a mood disorder. Borderline personality is a personality disorder. But more specifically, when you're thinking about those ups and downs between bipolar and borderline personality disorder, the ups and downs in bipolar are more ups and downs of like being elated and then really dysphoric, really depressed. Whereas the ups and downs in BPD, of course, can vary, but it's less elation. It's more an up and down of like intense rage and then dysphoria, like just feeling bad. So the ups and downs look different. Also, the ups and downs in bipolar disorder are what we call sort of more endogenously driven. It's more of a biological process, whereas the ups and downs in BPD, they're really driven by events that occur in the environment that set someone off. So, for example, a breakup will very predictably have somebody with BPD experience like a very intense range of emotions. And of course, to some extent, that's true for all of us. But in addition to that, what was I going to say with bipolar disorder? I think one of the pieces that's really important in terms of the diagnosis is also the emotions don't last as long with BPD, and they can be regulated much more easily with a number of skills, for example, that we use in dialectical behavior therapy. Whereas with bipolar disorder, those highs and those lows tend to last for a few days to a few weeks. So that's very different. So they're quite different. And then, of course, it's important to figure out what it is, because with bipolar disorder, one of the number one treatments is medication, and that's not true for BPD.
So when you have co-occurrence,
Yes.
how does a clinician go about treating both? I mean, you've touched on this, but speak
so you
specifically
absolutely
to that.
Yeah. So it's funny. That's a lot. That's a lot to have bipolar disorder and BPD. And so you do need a lot of support, I think. And typically what would happen after some really good assessment and figuring out where the areas of challenge are is somebody would probably be prescribed a mood stabilizer to help with the bipolar piece, and then do the interventions that we're more likely to do in DBT to address the BPD. That being said, I would say there's probably no harm in doing DBT with somebody who's just got bipolar disorder who could benefit from learning more skills around how to regulate emotions and how to take care of themselves, how to manage distress. I want to just note, Jeff, that we didn't get to, I think we just kept moving the cause as much. I spoke about heritability, but I didn't speak about the rest.
Let's circle back to that. Absolutely.
Okay. All right. So when we're thinking about the causes of BPD, as I mentioned, there's the heritability component. The serotonin system is a big one. So is the dopamine system. There's a few others. And then in dialectical behavior therapy, Marsha Linehan is the developer of dialectical behavior therapy. She proposed what we call the biosocial model, which I have found to be so incredibly helpful in helping to explain to families how one comes to really struggle, or how we think one comes to really struggle with emotion dysregulation and BPD. And so the idea with the biosocial model is that, as it sounds, there's a biological part, there's a social part. So the biological part is, as we talked about, it's the heritability. It's the biosocial model has been adapted to include more attention to impulsivity. So it's the fact that you can inherit impulsivity, and that puts you more at risk of developing BPD. And then we talk about people with BPD as struggling with emotion vulnerability, which is heritable. And so what it means to struggle with emotion vulnerability is that you really struggle with three things. And I encourage viewers who are listening to think about yourselves, just to think about sort of, okay, well, how am I, where am I on this spectrum? Where am I on this spectrum? It can be helpful to think about. So the first one is emotion sensitivity, which essentially, if you're really sensitive, it means that there's just more events in life that set you off. Something that you feel is like, oh my gosh, you have a big reaction to. The person next to you is like, on another planet, not noticing. It's not a big deal to the other person. But someone who's highly sensitive is noticing a lot and taking it in. And so that can be really, really painful. I also want to highlight, and I think this is really important to highlight, emotional sensitivity can be a huge gift, right? So people who are really emotionally sensitive might be phenomenal artists. They might be phenomenal therapists. I certainly am emotionally sensitive. I notice things. I pay attention to things and I feel them. You can be a really wonderful caretaker. You're really attuned to the people around you. Folks with BPD who have this emotional sensitivity, I would say some of these people that I've worked with are the most compassionate, creative, sort of hilarious people I've met. And in part, I think that's because of the sensitivity. So it can be a gift. You just have to figure out how to harness it. Then there's should I keep going?
Oh, please.
Okay. Then there's the reactivity, which is you have an emotion that shows up. And when that emotion shows up, it's big, right? And so that's you didn't get a little irritated by this person who was driving, erratically on the road. You are furious, you're honking your horn, you're swearing, you're sweating, right? So you feel the emotions very, very intensely. And then the third is that you might struggle with a slow return to baseline. So somebody can be really sensitive, but when they have a big emotion, they recover very quickly. Folks with BPD, it usually takes longer to recover from the emotion. So from emotion science, we know that emotions really only last a matter of seconds. But people will struggle with these emotions for much, much longer because their return to baseline is slower, and they might be doing things in their mind that prolong the emotion, like perseverating. So that's the emotional vulnerability component. So you're essentially born with. We're thinking that's the biological piece. And so if you're a person that's really emotionally vulnerable, what we think with the biosocial model is that it can intersect poorly with an invalidating environment. And so to be really clear before I get into this, DBT is like a no blame treatment. We're just trying to understand sort of how vulnerabilities intersect with the environment. And so if somebody, invalidation can look like a bunch of different things. Essentially, on the really benign level, it's sending somebody the message that their thinking or their emotions are wrong, but you can do it in a really kind way. So if a kid comes home and says, Mom and Dad, I'm so stupid, I did terrible on my exam, and the parents say, Are you kidding me? You're so smart. You got an A last week. That's really kind, right? But it can feel actually profoundly invalidating and sends the message to this kid that you can't trust your emotions, you can't trust your experience. And then sometimes what happens there is the kid then goes underground if they're consistently receiving messages like that, because parents or educators or even clinicians accidentally, sometimes everybody, it's accidental, when it's well-intentioned, are sending the message that, no, you're good, and not making enough room to hear, but you feel really bad, right? They're not doing that. And so the kid turns it inwards, and then eventually, right, the emotions become unmanageable and they have to figure out how to manage them. And that's when they might go to self-harm. That's when they might go to substance use. So that's the really sort of benign form of invalidation. And of course, everybody, I would say, is inadvertently invalidating at times. For this to really become an issue, it's an environment in which it's happening a ton. And again, with that well-meaning invalidation, we kind of think about it as just a mismatch of environments, like a tulip in a rose garden, right? It's not that the rose garden is bad in any way, shape, or form. It's just different. And so the rose garden may not understand like the needs and feelings of the tulip, right?
That's a great
Um,
analogy. Yeah.
so then invalidation can also be much more severe. So on the other end of the spectrum, of course, is sexual abuse, physical abuse, neglect. Those are absolutely linked with the development of BPD. The research shows that neglect and sexual abuse are probably the most directly and strongly linked to the development of BPD out of all of these forms of invalidation. So there really is a spectrum, but the idea is when somebody has these vulnerabilities and then they grow up in an environment where they are exposed to persistent invalidation, that is what's likely to sort of bring BPD to life. I also want to say, too, in terms of invalidation, it can exist at a really systemic level. So LGBTQ identified adolescents, right? Or adolescents, BIPOC adolescents, they're receiving messages from the environment at times, that their identities are not okay. So structural racism is a form of invalidation, right? Homophobia, transphobia, these are forms of invalidation, which can have very serious impacts on one's well-being.
This is such important background, and I love the insights that you've shared here. I want to dive into treatment a little more deeply here. You've talked a lot about DBT.
Yes.
Is that the gold standard for treating BPD? And what should we know about DBT?
Yeah, it is absolutely one of the gold standards. The research is very, very strong. It's an empirically supported treatment, evidence-based treatment. There's probably the most research out there for dialectical behavior therapy. And there are other treatments which I can speak to quickly, but to tell you a little bit more about DBT, that'd be good.
Please.
Okay.
Specifically for adolescents as well.
Yes. So DBT for adolescents, and adults, it's a multimodal treatment. And so there are many parts of the treatment. So it can be quite intensive. But with adolescents, what you're doing is you're engaging in individual therapy. And in therapy, in DBT, it's very structured. You create what we call a treatment hierarchy, where we prioritize what to deal with, because folks with BPD often come with so many challenges and we need to figure out, like, where do we start? And so the hierarchy looks like we prioritize life-threatening behaviors. So if there's anything life-threatening, that's where we start. Then we go to therapy interfering behaviors. So for example, if you're not showing up to therapy, if you're not doing your homework, then you're not going to benefit as much from therapy. So we're going to really target that. Then we're targeting quality of life interfering behaviors, which is, the depression, the anxiety, whole sorts of other, challenges. And then skills as well are really big. So you're doing the individual therapy. And then this is really quite unique to DBT. You have access to skills coaching, often by phone with your therapist. And so you are going to a group. So there's three modes now. So you've got individual therapy. You go to a group, and with adolescents, it's often a multi-family skills group where the parents and adolescents are together learning the skills for managing these challenges that come with BPD. And so there's 5 modules that we talk about for adolescents, and they are interpersonal effectiveness, so learning how to navigate relationships more skillfully, emotion regulation, figuring out how to understand like what it is you're feeling and how to better manage those emotions, distress tolerance, skills that help you figure out how to get through a crisis without making it worse, and how to bring some radical acceptance, for example, to the things you can't change, and mindfulness, which is really key. So those are the 4 in standard DBT. And then the 5th, which is added for adolescents, is the module called Walking the Middle Path, which is really focused on, teaching parents about validation. It's teaching kids about dialectical thinking. And that piece is really important. And then the other piece of DBT that's important, and, especially for therapists, is the consultation team, where the therapists come together once a week in consultation team. And sometimes we refer to it as therapy for the therapists, because this is hard work and you can burn out, and nobody wants a burnt out therapist. And so the idea is we come together, we sort of really hold a compassionate lens in working, when we're thinking about our work, and we support each other. So that's, DBT in a nutshell.
And I have to interject this real quickly because,
Yes.
again, great viewers here. Right on cue, a question came in. What can clinicians who work with patients living with BPD do to manage burnout, which is what you just referenced?
So if you are on a DBT team, that really helps. You actually can't say you're doing DBT if you're not on a DBT consultation team. That is one of the parts of doing DBT with Fidelity. And so the consultation team is huge. I also think, other things to manage burnout, a lot of the assumptions, agreements that we use in DBT really help our frame of mind for how we work with this disorder. So for example, we have an agreement called the phenomenological empathy, which is essentially saying that when we're working with our patients and we don't understand their behaviors, in the absence of an alternative explanation to understand why this kiddo did this, we're keeping in mind, we're trying to come up with the most non-judgmental, really compassionate interpretations of their behavior. So I think when you go to burnout, it's often driven by judgment. So clinicians really struggle when they get stuck in judgment, like somebody's doing this on purpose, someone's being manipulative. All of these negative judgments really increase our burnout. Other things that increase burnout are feeling like we're just really lacking compassion and we're feeling ineffective. So if you can target those three areas, that can certainly help with burnout.
An important question that's come in from a parent here. What can parents do when their teenager or young adult with BPD adamantly refuses to engage in treatment?
Really hard, and it can be really, really scary. I don't think there's one answer for this, but certainly one thing you can do is start the therapy yourself. And so you can join groups where you are learning about how to change your behavior, because at the end of the day, that's all you really can control is your own behavior. So when we're talking about resources, one of the resources that's just an incredible resource is Family Connections, which is done through the NEA-BPD website. Family Connections is a 12-week free course for parents and loved ones of folks with BPD to help them figure out how to be more skillful in managing BPD. So that's one. Another one that Family Connections is offering that's just incredible and developed by a number of my colleagues, Cynthia Kaplan, Alan Frazzetti, and Lucy Payne, is called the Managing Suicidality and Trauma Recovery program. And that's a program for parents who really feel traumatized by their kids' level of suicidality, by really scary suicide attempts. This is a program that has been really helpful in helping these parents learn to take the space they need to take care of themselves and to really get them support and access to good psychoeducation.
Let me hit you with another specific question that's come in here. Are there any gender differences in BPD? That's part one of the question. The second part is, can someone, quote unquote, outgrow BPD as they mature and learn more social norms, et cetera?
I can't believe I haven't answered the second question yet. Absolutely. So when you're thinking about myths with BPD, one is that it's just a disorder that's untreatable or that it never goes away. And actually longitudinal research shows that people with BPD tend to get better. So by your 30s and 40s, a lot of the symptoms of BPD really do decline. They're not as severe, just naturally. And then folks who get treatment, there are sort of follow-up studies that show huge percentages of people who no longer meet criteria for BPD after you get treatment. So I'm so grateful to you for asking that question. It is not a life sentence. It is highly treatable. Not for every single treatment doesn't work for every single person, but it can absolutely remit. In terms of the gender differences, I'm glad you asked. Historically, I think we think about BPD, or we have thought about BPD as a woman's disorder. And there's a lot of stigma attached to that. And actually, when you look at the research and the data in the community, it's actually equal prevalence rates among men and women. Now, there are much higher levels of women or numbers of women in treatment, and that, these women are seeking treatment more readily than men are. And I think clinicians are much quicker to diagnose BPD in women than men. But as we learn more, we see actually it's pretty equal.
Interesting. Another specific question that came in from a parent, Wendy. What triggers a person with BPD? Are there things that parents should say to their child with BPD, and are there things that parents should not say to their
Yeah,
child with BPD?
do a whole hour on this.
I bet we could, yeah.
Different things trigger different people, and I would say invalidation is just so painful for folks with BPD. And so one of the key things that I want parents to learn who have kids with BPD is to learn how to effectively validate. And you learn that when you engage in DBT treatment, you learn how to validate. There are also just books out there. There's a book, I think it's called I'm looking around for it, The Power of Validation for Parents. But really what that means is when a kid is telling you that they're struggling, you slow down, you make space, you get curious, and you reflect on how painful that must be instead of so quickly jumping to problem solving. Well, you should just do this. You should just go for a run. You should just call that friend. You'll feel better. That can feel to somebody with BPD or just someone who's really sensitive, very, very invalidating. And then, of course, interpersonal distress, interpersonal events can be a big trigger to behavioral dysregulation. So, for example, a breakup, a fight with a parent, feeling rejected by a friend, all of that can be really hard for folks with BPD.
Another important question. How do parents go about finding effective care? Maybe specifically, how do you find a DBT practitioner?
Yes, so there's not enough of us, and I think the field is continuing to grow. McLean certainly has a ton of resources for folks with BPD and a number of programs that are specialized in working with BPD, both with adolescents and adults. NEA BPD can link you to resources as well, Family Connections. Also, just a resource for parents while we're at it is the Sash Bear Foundation. It's just an incredible organization, and they provide a ton of webinars from experts who talk about this topic and help parents understand, things like Psychology Today. It's a website where you can look up different therapists, and in there they list what their specialties are. So there's a number of different ways to find these therapists and these programs.
Wendy, we often have a lot of educators in the audience as well. What do you want to share with them in terms of signs to watch for in their classrooms, ways that they might educate themselves, when to involve parents, when to involve professionals? What do you have to say on that front?
Yeah, that's such a broad question, but I would say in terms of like the warning signs that we discussed earlier. So if you see someone who's really struggling with irritability, if you see an adolescent who's struggling with intense risk behaviors, you see signs of self-harm, that certainly should be a red flag. Continued absences can be indicative of a real problem. I'd say it doesn't hurt to talk to the counselor when you see these concerning signs. And you want to talk to the kid as well. I think oftentimes with adolescents, we go around them and we talk to parents first. And I think really respecting an adolescent's agency and their own ability to know themselves is important. And so checking in with the adolescent, I noticed you've been struggling. And then bringing in some validation. So if you understand at all why they might be struggling, this is a really hard time of year. Or I know you had that argument with your friend last week. Like, I know that was hard. Like, do you want to talk more about it? Sort of like gentle, curious, and really validating to sort of lean in and certainly, consulting with professionals as needed.
We've talked a lot about resources along the way. You've mentioned a number across the past hour. Are there any others you want to put out there? Any ones you want to highlight as we start to wrap up the webinar today? Because it's so important for people to know where to go to get additional information.
Right. So all the resources I've mentioned are really amazing. In terms of books, one of my colleagues, Blaise Aguirre, wrote Borderline Personality Disorder for Adolescents. That's a really good one to help parents understand what BPD looks like in adolescents and how to support them. Another colleague of mine, Michael Hollander, these are both mentors, wrote Helping Teens Who Cut. That one's really helpful. There's a great mindfulness book for folks with borderline personality by Gillian Galen and Blaise Aguirre. These are all my colleagues' books. But there's actually a ton of books out there. There's a great one, Beyond Borderline, edited by John Gunderson and Perry Hoffman, that speak to the lived experiences of people with BPD. That might be really helpful. But there's a lot out there.
Right. And we will link up those resources to the webinar page when we're all set and done with this as well. Wendy, we like to wrap up these webinars on a very positive note, and you've shared certainly a lot of reason for hope throughout the webinar as well. But I would love for you to end by speaking directly to, say, a parent out there who might feel overwhelmed by this topic, really concerned about a child or an adolescent. Speak, if you would, to the hope that is afforded through treatment and the success stories that you have seen through your work.
Yeah, so to the parents, and this is something we believe in DBT, and I truly mean it. I think it's important to remember that at this point in your life, you're doing the absolute best you can with the resources you have. You can always do better, and we can help you do better. But to be kind to yourselves, you're doing the best you can. It is wildly difficult to manage, honestly, to be an adult, or to be a human being, and then to manage a child who's struggling so much, who's engaging in scary behaviors. It's wildly stressful. And so I think, take care of yourself. That piece is really important. And also, most people who get treatment, evidence-based treatment, do better. I have just seen so many people across the years who were in such dark places, both parents and adolescents, and now they're in college, they're graduating from college, they're getting jobs, they're sort of back on track. So it's absolutely possible. I think getting hooked up with good resources is critical.
Great place to wrap things up. Wendy, can't thank you enough for your time and your expertise today. We so appreciate your making some time for us today and the important work that you're doing day after day. Thank you. And to those who are watching, we do thank you for your interest in our educational webinar series. We hope you'll come back for our future sessions, and we wish you a wonderful day.